The notion that if someone has the disease of addiction, that they somehow make the choice every day to alienate all their friends and family, jeopardize their job, lose their housing, run into the law, that actually people would choose this as a way of life. No human being willingly has that as a life if they can avoid it.
It doesn't matter if you're rich or poor or black or white. Pretty much everybody now knows somebody who has lost somebody because of opioids or because of heroin.
It's inexcusable that brain disease is treated differently than other diseases. It's not mental health versus physical health, it's just plain health. Prescription opioid and heroin addiction is devastating children and families, decimating communities, urban, suburban, rural, and is the #1 accidental killer in the United States, even outpacing car crashes, with 47,000 lives lost in 2014 alone.
So look, in all too many cases, somebody's they're just doing what the doctor told them to do. Okay, they go to the doctor says, here's a big jar of pills. And they take the pills and their lives are destroyed. It shouldn't be that way.
Brain science is very rapidly teaching us more and more about the brain. And what we're learning is a couple of big ideas. First, that the brain can actually become physically addicted. It changes when you become an addict. Second, that some opioids are very powerful and people are predisposed to becoming addicted. And third, that there are medication interventions that can have a dramatic impact on helping you recover and literally save your life from the addiction you might have. A study published by the New England Journal of Medicine 14 years ago showed people were 3.5 times more likely to not use an opioid if they were in a treatment program that included medication. The National Institutes of Health, the World Health Organization, and countless medical societies say that medication-assisted treatment is essential to effective long-term recovery. So why is it that only 15% of the patients are being treated with what ought to be the gold standard for opioid recovery?
We need to have a personalized approach to medicine in addiction like we do with other illnesses, and that means we need all the tools on the table so that we can treat this illness with the urgency that it deserves. The evidence base says that you need opiate replacement therapy in order for people to stabilize their lives and for some get into long-term abstinence-based care. But that's not a given. The brain needs to be treated for a medical illness like any other organ of the body. Like insulin would be given to someone with diabetes, opiate replacement therapy should be given to people with opiate dependence and addiction.
It's hard enough when somebody's addicted for them to finally say, I want help. I need help. That's supposed to be the victory. That's actually often the beginning of the nightmare. Guess what? They go to the doctor. They can't find a doctor to help them. The doctor says, I'll help you, but the insurance companies won't pay for it. And they go from a nightmare of addiction into a nightmare of bureaucracy, and then they wind up all too often dead. Okay? Now, if we were treating people who had heart attacks in this way, oh, you got a heart attack? Well, we need 4 weeks of paperwork and we've got to get permission. There would be people up in arms. We should be up in arms about this.
Let me make clear how really wrong the current model is. Imagine if you had diabetes and you went to see the doctor, that 80 out of 100 people who showed up diabetic didn't get any help at all. That of the 20 who showed up, some 17 got the wrong help. And so only 3 got the scientifically most effective treatment, which, of course, the diabetes is insulin. Well, we'd all know that that was nuts, and doctors would be up in arms. Yet that is exactly the current situation. Our goal is simple: more long-term addiction survivors. We are pursuing 4 strategies. First, we're educating people. Real recovery treatment for the disease of addiction includes medications. Second, we are promoting policy changes that eliminate barriers to treatment, such as arbitrary caps that still exist on the number of patients a prescriber can treat at any one time. Third, we are focused on the criminal justice system. We support drug courts that help nonviolent drug offenders stay out of jail and stay in recovery. Finally, we need to remove insurance barriers to real, meaningful treatment. No dosage or lifetime limits, no policies that require counseling before someone can access medication, no cumbersome pre-authorization process.
This epidemic is solvable. It takes political will. We need to have a conversation to get that started. We need to pursue better public policies. We need to reform our insurance system. We need to address this as the criminal justice reform issue of our time. We can do this. It begins with us changing the conversation.